Hello friends, I am Dr. Ankit Goyal. Today we will discuss the questions of psychiatry from the Grand Test 181. So let us start with the first question. Now question 35, which statement is true with regard to development of a transference neurosis in psychoanalytic theory or the psychoanalytic therapy? The correct answer is option C. It is an integral part of therapeutic process. Now answer to question 35 is option C. Now let us discuss some of the important aspects of the psychoanalytic therapy. Now psychoanalytic therapy is based on the psychodynamic theory Now psychoanalysis is the term which was coined by Sigmund Freud. Who is also known as the father of psychoanalysis. Now according to the psychodynamic or the psychoanalytical theory, the unconscious conflicts and childhood memories and experiences, they play an important role in development of the human behavior and even the psychiatric disorders. So this is the basis of the psychodynamic theory, that the conflicts, the unconscious wishes, desires, as well as the childhood memories and experiences, they are playing an important role in the development of our behavior, the way we are, the way we respond to various issues or various things around us, as well as they also play an important role in the psychiatric disorders. Now in the therapy, transference also plays a key role. Now, transference plays a very important role. So what is transference? Transference is defined as the conscious or unconscious feelings or emotions. These are the conscious and the unconscious feelings and emotions of the patient. So important to understand that these are feelings, emotions of the patient towards the therapist. So towards the therapist or the doctor. So important to remember, these are feelings or emotions of the patient which are towards the therapist, and these are based on past relationships with a significant other in the patient's life. So for example, a 20-year-old girl who is seeing a 45-year-old therapist, and subsequently she starts to feel that the therapist is just like a father whom she lost around 10 years back. So he is as caring as the father. So there will be development of feelings or emotions towards the therapist which are based on a past relationship of a significant other which the patient had. So this is what is known as transference. Another important concept in the psychodynamic therapy or the psychoanalytic therapy is the concept of counter-transference. Now, in counter-transference, these are conscious or unconscious feelings or emotions of the important, now these are of the therapist towards the patient. So now these are counter transferences which are feelings or emotions of the therapist towards the patient. Now what is the role of these, of the transference or counter transference, especially transference? They are essential part of the treatment, as once an old conflict, so once the old conflicts are brought into the awareness, subsequently them, we can understand them, as well as finally they can be resolved. So hence they play an important part in the therapy. So the correct answer is option C. Now other options, it only occurs in very early stage of the treatment. Again, this is a false statement, as they can occur in any stage of the treatment. It only occurs in patient with severe psychopathology. Again, it is false. It can occur even with person with mild or moderate psychopathology. Option D, it usually involves the reenactment of adolescent power struggles. Again, it is false, as we had discussed transference, or what is transference neurosis. So option C is the correct answer amongst the following. Now question 36. Now question 36, a young executive is periodically required to give reports in front of the firm CEO. Although usually he is confident and well prepared, the young man becomes very anxious prior to the presentation. Once he is in front of his crowd, he experiences dry mouth, heart palpitations, profuse sweating, which are symptoms suggestive of there is some anxiety symptoms are there. Then which is the correct statement? Here in this, the correct answer is option D. Cognitive behavior therapy has been proved to be effective. Now let us discuss question 36. So the answer is option D. Now in this question we are dealing with important anxiety disorder known as social anxiety disorder, or also known as social phobia. Now social anxiety disorder or social phobia, here the fear, there is fear of social situations, including situations that involve scrutiny or contact with strangers. So it is a fear of social situations, including situations which involve scrutiny, as in this case the person was asked to prepare the presentation, present various presentation toward the firm CEO. So he may be exposed to some scrutiny, or also sometimes when there is contact with the strangers. Important to understand in social phobia or the social anxiety disorder is that persons with social anxiety disorders, they are fearful of embarrassing themselves in social situations. So they have a fear of embarrassing themselves. So and rather than, they're not fearful per se of the situation. So there is a fearfulness of embarrassing themselves in social situation and not the situation itself. So for example, a person goes to a family function or to a wedding. Subsequently, he is not afraid to, the direct fear is not of the situation, but of the fear of he may embarrass himself. For example, while eating food, he may be embarrassed that if he spills, then there may be time of embarrassment. So they are fearful of these embarrassing situations. Now, if we see epidemiology of social anxiety disorder, now there is some controversy in the ratio of males or females affected more. Generally, it is seen that in the clinical sample or the patients who come for treatment, males are more than females, while in the epidemiology studies, it has been found that females have more social anxiety disorder than the males. Also, the peak age of onset of social anxiety disorder is the adolescence. Important. Now coming to the treatment. Now treatment of social anxiety disorder, social phobia is both pharmacology or pharmacotherapy as well as psychotherapy. So it's a combination of both. In pharmacotherapy, the first line treatment is generally the SSRIs or the selective serotonin reuptake inhibitors, while there are other drugs which may be used are the benzodiazepines like clonazepam, then venlafaxine, buspirone. These are some of the other drugs that can also be used. Again, while in psychotherapy, the treatment of choice is cognitive behavior therapy, which includes various cognitive as well as behavioral techniques. For example, cognitive training, desensitization, cognitive training is one of the cognitive techniques used, desensitization is one of the, it's a cognitive technique, while desensitization is a behavioral technique. So a combination of cognitive and behavioral therapy or the CBT is also used, and in fact one of the first line psychotherapies for social anxiety disorder. So in the question, option A, females have a higher prevalence. Again, it's a controversial statement. Clinical samples, male more affected. Epidemiological studies, females more affected. Then onset in adolescence is rare. Again, it is a false statement, as we know that the peak age of onset is the adolescent. Then medications are not effective treatment options. Again, this is a false statement. You have seen medicines have a good effective control, especially the SSRIs. Then the cognitive behavior therapy has been proved to be effective. This is very correct as we have discussed. So the right answer would be option D, that is cognitive behavior therapy has been proved to be effective. Now let us discuss the next question. Dopamine hypothesis was given for the etiology of The correct answer is option A, that is schizophrenia. Now let us discuss about the dopamine hypothesis. According to the dopamine hypothesis, it states that there is too much of dopamine, which leads to development of schizophrenia. So subsequently, how did we reach this hypothesis? The two important observations which actually led to the making of this hypothesis. The first is the efficacy of the antipsychotic drugs. Then initially it was seen that the antipsychotics, especially the typical antipsychotics or the first generation antipsychotics, when they were initially discovered, they had a very good effect or efficacy towards the psychosis or schizophrenia. And it was, as we generally know, that the typical or the first generation antipsychotics are basically dopamine antagonists, especially D2 antagonist. So it was believed that probably there is an increase of dopamine. That is why drugs which are blocking the dopamine receptors, they are having the effects. Another observation which was seen was that drugs that increase dopamine, like cocaine, amphetamines, they are psychomimetic. That is, they produce symptoms like the psychotic symptoms. So based on these two observations, a dopamine hypothesis was given. Now we know that because of more observations and more research, now it has been seen that there are certain various tracts of dopamine which are affected in the schizophrenia. So let us discuss some of the important tracts. The first is the mesolimbic tract. So we are discussing various dopamine tracts. So the mesolimbic tract. Now mesolimbic tract runs from the ventral tegmental area VTA in the midbrain. So that is why the name meso, to the limbic region, especially the nucleus accumbens. So it is running from the midbrain to the limbic system. Now it is seen that there is an increase in the dopamine levels in this tract, which actually leads to development of the positive symptoms in schizophrenia. Now as we know, positive symptoms means delusions and hallucinations. In fact, there is an increase in the dopamine in the mesolimbic tract, which leads to development of positive symptoms. Then there is another tract, mesocortical tract. Now again, this runs from the midbrain ventral tegmental area to the cortex, especially the prefrontal cortex. Now it is seen that in this tract, in schizophrenia, there is a decrease in the dopamine levels. So not only there is increase, but also in the other tract, in the mesocortical tract, there is a decrease in the dopamine. and which leads to development of the negative symptoms. So negative symptoms like anhedonia, avolition, alogia, asociality, these are some of the negative symptoms, as well as also it is responsible for cognitive symptoms. So there is also cognitive decline in the patients of schizophrenia, and these cognitive symptoms are because of the decrease in the dopamine in the mesocortical tract. So again, important to remember these tracts. There are other two important tracts, Nigro striatal tract This tract basically runs from the substantia nigra the midbrain through the striatal or to the striatum in the basal ganglia. Now, as we know, we give antipsychotics which block the dopamine receptor, especially the D2 receptors, and blockage of dopamine in these receptors leads to the movement side effects, also known as extrapyramidal symptoms or extrapyramidal side effects, or the EPS. So these are the movement disorders or the drug induced or the neuroleptic induced movement disorder which are seen with the antipsychotics. And the third and the fourth important pathway is the Toubro-Infundibular pathway. Now this runs from the hypothalamus to the anterior pituitary. Now, as we know, normally in the body, dopamine decreases prolactin. So normally this feedback is seen in the body. Now when there is blockage of dopamine due to the antipsychotics, subsequently this leads to increase in the prolactin in the body. So the prolactin is increased. There is a hyperprolactinemia seen in the body with this is one of the side effects again of the antipsychotics, which lead to, in females, this may lead to decreased libido, galactorrhea, as well as also may lead to amenorrhea in females, while in males it may lead to again decreased libido and also lead to sexual dysfunctioning or sexual disorders. So this is one of the important tracts for patients with schizophrenia. So the answer of question 37 is option A, that is schizophrenia. Now let us discuss the next question. The following pyramid is called as. Now this pyramid, where there are various levels: physiological, safety, love, belonging, esteem, self-actualization. So this pyramid is known as option A, that is Maslow's hierarchy of needs. So let us discuss about this. So answer to question 38 is A. Now Abraham Maslow gave a self-actualization theory. He gave a self-actualization theory, which is also known as the Maslow's hierarchy of needs. Now, according to this Maslow's hierarchy of needs theory, as our primitive needs are satisfied, so as our primitive needs subsequently the above needs becomes our primary motivator. So once our primary or the primitive needs are satisfied, subsequently we move to the above needs, subsequently they become our primary motivator to do the things which we do. And Maslow gave this hierarchy in which the first need or the most primitive need which he gave was the physiological needs. Then there were the safety needs. Subsequently, then there were the needs or the belongingness or the love needs. Then there were the esteem needs. And the topmost need is the self-actualization. So this is the peak experience according to Abraham Maslow. So this is the peak experience, also known as being needs or the being needs or the be needs. While these needs or the needs below the self-actualization, these are known as the deficit needs or the D needs. So this is about the Maslow's hierarchy or the self-actualization theory. Let us discuss the next question. So let us discuss the next question. In this question, a 35-year-old man is diagnosed with a major depression. Started on sertraline 25 mg a day. After 1 week, the doses increased to 50 mg a day. Patient remains depressed and does not respond to the sertraline. Then what is the most appropriate next step? So out of the options, the next step, the most appropriate next step is option C, that is increase the sertraline dose. So the answer to question 39 is option C. Now let us discuss the management of a depressive episode. How do we manage a depressive episode? In the management of depressive episode, first we need to know what is an adequate trial. Now, adequate trial, we say that a drug is effective or to be called a drug to be an effective drug, we should have given the drug for at least adequate duration, which is generally around 4 to 6 weeks in cases of depression, as well as with the usual or the adequate dosage. So if we have given a drug with a adequate duration and an adequate dosage, then we call that we have performed an adequate trial, and only after having an adequate trial, only then we can decide whether the drug is effective or not. So as in this case we have only given the drug for a week, so we cannot say that we have adequately given the trial. Also, let us remember some of the important adequate dosage or the usual dosage of some of the important antidepressants. Now, important usual doses of SSRIs like sertraline is 50 to 200 milligrams per day. Fluoxetine is 20 to 80 milligrams per day. Escitalopram is 10 to 20 milligrams per day. Paroxetine is usually 20 to 60 milligrams per day. Citalopram is generally 20 to 40 milligrams per day. Then fluvoxamine is around 50 to 300 milligrams per day. So these are some of the important usual dosage of the various SSRIs. So as in this question, we would say the best answer would be that we need to increase the dose of sertraline and then subsequently decide whether the drug is effective or not. Now let us discuss the next question. Every 4 to 5 weeks, a 32-year-old woman experiences few days of irritability, tearfulness and unexplained sadness. During these days, she also feels fatigued, bloated and also eats large quantities of sweets. So what is the most appropriate diagnosis? So the answer is option D, that is premenstrual dysphoric disorder. So let us discuss option of question 40. The right answer is PMDD, that is premenstrual dysphoric disorder. Now let us discuss about this. Now earlier this was added in the previous DSM, that is DSM-4, in the late body or in the research criterias, while now it has been shifted to the main body of the DSM-5. So now it has been added in the main body of DSM-5. Now generally, what are the important clinical features of PMDD, that is premenstrual dysphoric disorder? Now here these symptoms generally occur during the majority of the menstrual cycles, and they have symptoms which have an onset in the final week before the onset of menses. They start to improve within few days of onset of the menses, and subsequently they generally show complete improvement, or they generally resolve completely. Just after a week post menses. So they have a pattern. They have an onset which is 1 week before the onset of the menses. They start to improve within few days of the start of menses, and subsequently 1 week after the menses they generally are completely improved or completely resolved. So this is the pattern which they generally have in consecutive menstrual cycles. Now what are the important clinical features which may be seen? Now clinical features include mood symptoms, so they include mood symptoms in the form of, they may be irritability, lability of mood, there may be depression or depressive symptoms, as well as there may be anxiety symptoms, and at least one of these symptoms should be present. So at least one of the mood symptoms should be present. Then there may be physical symptoms, in the form of, there may be tenderness in the breast, there may be edema, there may be pain. So there may be certain physical or the somatic symptoms. Then there may also be certain behavioral symptoms. Which may include lethargy, decreased sleep, disturbed appetite. Appetite may increase or may decrease. There may be decrease in the concentration. Also the sleep may be decreased or it may be increased. So there may be disturbance in the sleep as well. So these are some of the behavioral symptoms which also may be seen. So there are basically mood symptoms, then there are basically somatic symptoms or the physical symptoms, and also there are associated behavioral symptoms. And generally the treatment remains pharmacotherapy, in which drugs like we can give SSRIs, also we may give benzodiazepines, as well as psychotherapy. So these are the two important modalities. Now important to understand is the differential diagnosis, disorders which may help or which may create problems while diagnosing. So first is the premenstrual syndrome. Now here important differentiating features from PMDD is that it has less symptoms. Generally it is premenstrual, that is it is generally before the menses and generally improves with the menses, while in PMDD symptoms may resolve after a week of the stoppage of menses. Also there are generally physical or behavioral symptoms which are more present, for example tenderness, edema, decreased appetite, lethargy. These are the important symptoms where mood symptom may or may not be present. Then second important differential is the dysmenorrhea. In dysmenorrhea, there is basically the symptom is classically the pain which occur during menses or just begins with the onset of menses. So again important differential diagnosis which we must be aware of. So this is about the psychiatry portion of the Grant Test 181. Thank you.